Good morning and welcome to GHI Grand Rounds. Thank you all for joining us. I'm pleased to share that today's presentation has been awarded credit for physicians, nurses, radiology techs, and EMS. This program is brought to you by Georgia Heart Institute with the generosity of grants from our industry partners. The planners have disclosed no relevant financial relationships with commercial interests. Dr. Schuler will disclose his relationships in his presentation. To claim credit today, take our online survey. The link to that will be shared at the end of the program and in the Zoom chat. If you have a question for Dr. Schuler, please hold until the end of the presentation. And now to introduce our guest speaker is Dr. An.
Oh, okay. Hi, good morning. It gives me a great pleasure to welcome back Brian Schuler for giving today's Grand Rounds. Just to give you a little bit of background, Brian and I were co-fellows at Emory, so I've known him for a long time, and always kind of admired kind of his innovative thoughts and great ideas. He always comes up with amazing ideas that he shares with us. So he's currently the section chief of clinical cardiac electrophysiology at WellSpan Health, which is an integrated healthcare delivery system in South Central Pennsylvania. And he's a member of the Heart Rhythm Society, fellow of the American College of Cardiology, and board certified in both clinical cardiac EP and cardiovascular CT. So he graduated at Emory, both cardiovascular disease, and did his fellowship at Emory as well. Finished in 2006. He's developed a sterling reputation as an EP, and he has been really a key opinion leader in the areas of transeptal puncture, lead extraction, AFib ablation, and left atrial appendage occlusion therapy. So as well as cardiac CT. He's been a principal investigator in multiple trials, the Option trial, the Amulet trials, Pinnacle Flex, Catalyst, Champion, all of these left atrial appendage occlusion trials that are just basically groundbreaking trials. Also in the ablation field as well. He's started multiple programs for left atrial appendage occlusion, lead extraction, and AFib ablation at his site. Again, welcome, Brian. He's going to give us a talk on CT-Angio Suite, unlocking the power of advanced imaging in the EP Cath lab.
Thank you. Appreciate Dr. Samity and Dr. An for inviting me back. And I always feel welcome here. It's like a second home for me. So most of the time when I give these talks, I got like 10 minutes. Or I gave one, I had flown out to California, and I had 8 minutes. I was telling June about it last night. So I flew all the way out to California, and I had an 8-minute talk. So today I actually get to elaborate a little bit more. So I think the first time I did a talk for Habib, he said 18 slides max, and I had 81, and I did it in, I think it was 15 minutes. So it won't be so pressured today. So I'm a consultant for Canon and for Boston Scientific. So today we're going to demonstrate I hope to demonstrate the utility of the CT-Angio Suite for EP and Cath procedures, demonstrating the power of CT-guided appendage occlusion, closure of percutaneous leaks, or peri-device leaks, sorry. CT fluorofusion, same setting, CT-guided cardioversion, and same setting coronary CTA PCI. So a little bit of the EP lab, some of the Cath lab, and some of this is groundbreaking work from my partner, Stuart Benton. We're also going to review data demonstrating the incidence and clinical impact of peri-device leak. We're going to review data strongly suggesting that CT-guided appendage occlusion should be the gold standard for peri-device leak prevention, and that's with our own data. And then review data demonstrating the CT-Angio Suite wins both in a fee-for-service world and a value-based care world. So this is the CT-Angio Suite. Really, it's the combination of a single fluoro table with 12-inch ceiling-mounted C-arm coupled with a 16-centimeter volume scanner. So you could imagine the type of procedures that you could do. But so in one respect, if you took a patient and you brought them in and they had chest pain, you could do a CT on them and turn around and intervene right there. And we'll show a case of that. You can take a patient that's far away that you don't know their anatomy, bring them in and do a CT of the appendage with delayed imaging and get their anatomy. And while you're working up the anatomy on the multiplanar reconstruction, they're being prepped and you just go ahead and execute the game plan. So it's a very unique environment, and it opens up a lot of possibilities when you start utilizing these two modalities. When we started this, it was really Bill Nicholson was convinced the administration that we needed this technology. Bill's pretty persuasive. I don't know if some of you guys know Bill. He's an Emory grad. We graduated together. So for other applications, the CT-Angio is actually a thing in interventional radiology and oncology and that kind of thing. So neurointerventional. But in cardiovascular world, this is the first one ever that was used for this application. So we kind of got this system put in place. And at that time, I was using more and more CT to kind of look at the appendage for left atrial appendage occlusion. And then right around that time, Bill took off, and we got the system installed in December of 2019. Bill took off. He went back to Emory and doing great things there. And then so here we have the system, and we had a guy named Mahdi Chaudhry who's fantastic. All three people here are Emory grads. So Mahdi ended up going on to the Brigham and got, he's an advanced imager from that program, which is a fantastic program. And so the three of us started working together, and then the pandemic hit, and I was like, well, I don't really understand this CT so much. I mean, I don't even know how to push, I don't know what I'm looking at. I don't understand what this stuff means. So Stuart and I went out and got level 2 boarded in cardiac CT through Johns Hopkins, and there's a number of these programs that you can do, and then from there we started building it out. But I think it works really well with a level 3 advanced imager, and then you really want to try to get your proceduralist CT boarded. It doesn't take long; it's like a 1-week thing, and then you can kind of get the foundation set. So in this CT-Angio Suite, I think of it as an integrated diagnostic and therapeutic arena where you can now do the same setting of a lot of procedures that would be separated in time and space. So same setting coronary CTA PCI is a good example. We do TAVR evaluations, left, right heart cath, and the Amish population, they basically pay cash. So we've got a large plain community, and they'll come in and they want it all done all at once. So they did the left, right heart cath, the coronary evaluation with CT and the runoff and all that, and then the TAVR all in the same setting. CT-guided cardioversion, same setting, CT of the left atrial appendage with left atrial appendage occlusion. And there's a couple of things that we haven't done. Like, for example, PE is an obvious place where this could be amazing, right? You could just make a whole career on it. And it's just, there's the possibilities are endless. Then there's also the novel CT-guided procedures, and I'm going to show you CT-guided left atrial appendage occlusion. There's other things we've done like CT-guided PFO ASD occlusion, and other kind of interesting ones like a pseudoaneurysm repair. So first topic that I'm going to really delve into is the issue of left atrial appendage occlusion and peri-device leaks. So the left atrial appendage obviously is the place where thrombus forms like 99% of the time. When the heart's quivering in AFib, there's sluggish flow, and you get a bunch of nooks and crannies out in the apex of the left atrial appendage, and you're going to form thrombus there. The sluggish flow results in coagulation of blood. So the idea is, if you have a patient that's a fall risk or a bleeder, that you seal this thing. You put a device in there that seals it, and you eliminate it from the equation. And so I got to give props to some of the companies, because when they first started doing this, they set the bar really, really low. They said, well, if it's less than a 5 millimeter leak, then that's a successful left atrial appendage occlusion. I guess if you set the bar that low, you're going to win. And that's really what happened. And so there was like this idea that it didn't really matter as long as the leaks weren't big. It didn't really matter. And that changed with Chris Ellis took his patient population at 4 centers, and Chris was a guest speaker, and he was on the dais with me a couple of years ago. Anyway, right around that time that we had the first symposium here, I was touting his work, and so They found an 8.3% risk of incidence of stroke in patients that had peri-device leak versus 2.7, so a threefold increase roughly. And they also found, interestingly, that if you had a leak less than 3 millimeters, the risk of the incidence of stroke was nearly 10%. So you ask yourself, okay, well, these patients that have small leaks, why is it that a small leak is more damaging than a bigger leak? Well, it turns out that in their patient population, the 51% of those with leaks over 3 millimeters were put on oral anticoagulation versus 16%. So there's a confounder there, and that is the confounder. So in essence, all leaks really do matter. And so the PROTECT AF and PREVAIL, which was the two studies for the original Watchman 2.5 device, and there's I think 1,000 patients overall in that cohort. That working group went back and looked at their data, and they had previously found that at 45 days it didn't predict anything. But when they looked at peri-device leak at 1 year, the risk of stroke doubles when you have a leak at 1 year. So it goes from 5.1 to 9.5%. And if you look at that chart sort of in the middle, you'll see there's a 28% incidence of leak overall, and only 0.7 of them were greater than 5 millimeters. That 0.5 millimeters is determined by TEE. It's the jet width. So it has nothing to do with the actual geometry. And if you study these things on CT, they're usually these sort of crescent-shaped things, and they're really like cutting a cross section somehow with the TEE to determine that sort of 5 millimeters. Muhammad Al-Khuli, I think, is brilliant, and he just put an article out in JACC Interventions that anybody that's doing appendage occlusion needs to read, and it has to do with device-related thrombus, and it's a state-of-the-art, it's a wonderful review that he put together. It's in this month's edition. But anyway, he took 51,000 patients and found that those patients, this is a 1-year follow-up, that there's a leak stroke association at one year in leaks that are less than 5 millimeters. So this confirms it. It does take some time for this to blossom, and you ask yourself why. Well, most of these patients were Watchman 2.5, and that regimen was actually oral anticoagulation for 45 days, DAPT for 6 months, and then they go to single antiplatelet therapy. So to me, it's kind of like, how long are they exposed to single antiplatelet therapy? And then you start to see the curve sort of divide out or spread apart. And you'll see that in the amulet IDE and the NCDR and in the Watchman trials that there's a difference always if you have a PDL. Some of them are significant, some of them are not, but the NCDR, it's definitely significant at 1 year, which is not a huge difference, but give it 5 years in the Watchman trials and you can see the doubling. And so then you ask yourself, well, what's the incidence of this? And I showed you 28%, but it's a lot. This is a large problem. Peri-device leaks are kind of a major issue. The Pinnacle Flex, which is the 400 patients to get the Watchman Flex approved, they had a 17% by TEE at 45 days. And so I'm going to show you some data a little bit later here that indicates that CT is much more sensitive than TEE. So most of these peri-device leaks that you see on here, this is all by TEE criteria. So if you wanted to compare peri-device leaks to device-related thrombus, so I'm sitting in some of these advisory meetings for one of the companies, and everyone was harping on device-related thrombus. And if you know that the new sort of Watchman device that's coming out has this coating that attracts albumin to try to shield the surface of the device from platelets. That's the strategy that they developed. But there were other people in the room, and they were saying, the peri-device leak problem is it's many more times the issue in terms of scope, right, as compared to DRT. DRT and the meta-analysis that Al-Khuli did in 2018 with over 10,000 patients is 3.8% pooled. If you look at PROTECT AF and PREVAIL, it's 3.7%, 3.9% in the amulet trial. And if you break that down, the amulet device, their DRTs are a little bit earlier because they're using DAPT, I think, but it's also could be the characteristics of the appendages and whatnot. But the bottom line here is that the outlier is the Pinnacle Flex, and our data of over 330, we're at 3.6% at 1 year. So I think it's somewhere in that 3 to 4% range, and that's what I tell our patients for risk of device-related thrombus. So this is the first in human intraprocedural CT. This is December 2019. We had like literally no idea what we were doing. But we connected a side port of a long sheath, and we connected to the dual source injector and delivered, at the time it was 50 cc's of contrast followed by a saline flush. And we did full cardiac cycle and 16 centimeters of coverage. And when you see this, I think it's pretty amazing, because you could see here like where the transeptal is in the angle. You could see that the appendage is a little bit darker. That the appendage is a little bit darker than the remainder of the body of the left atrium, meaning that contrast is struggling to get in here through this fabric. You can make arguments about this. I look at this implant today and I'm like, first thing is the Watchman Flex was such a dangerous device. I can't believe we did that procedure with those little prongs sticking out. And, I think it's too deep, and there's a lot of things that we would be all obsessing about today with a safer device that you can redeploy. So one of the things I'm going to kind of go through, and I've shown this case before, but how does CT actually help you? Well, the first one and the most obvious one is the axial alignment issue. So a lot of times with TEE, you can't get, in my opinion, you lose the ability to get sort of a frame of reference sometimes. But, you could say a 45-degree view is a 45-degree view, and we know sort of what that sort of looks like. But in CT, you could put it, you can basically validate things with 20/20 vision in a 3D multiplanar reconstruction sort of form. So there are a lot of times in TE, there are acoustic windows that don't allow you to get the views that you need. And you really need a 360-degree view around that device to know every little segment of the device. And if you do for example, a 135-degree TE view, you might have to clock and counter just to find what we find here on the CT. So a lot of times we'll do it, it looks good, we do the CT, we come back, we're like, where was that? And then, manipulation, oh, there it is. And it's this little tiny sliver of a cut. So anyway, this one's pretty obvious, because if the device is not aligned properly along the long axis of the appendage, you're going to get a leak here. And you can see that this right here is where the PET fabric will end. It's probably not the fabric itself. You can clearly see the fabric on TEE. There's argument about what this represents. I think it probably is the anchors, but the fabric ends at the anchor. So I'm using it as a surrogate, but this is definitely a leak. And so we had to reposition this device and get this to orient well. And then at 45 days, it looked great. I'm going to show you these two cases more in depth, but one of them is a depth adjustment. You have a posterior gutter that's getting up too close to where the PET fabric is. In one case, you've got kind of a same kind of situation here, and we've dealt with these in different ways, and I'll show that. So this is a depth adjustment case, 75-year-old with persistent AFib and sinus rhythm on amiodarone, CHA2DS2 of 5, has blood of 4 with GI bleeding. So this is a classic, a patient for left atrial appendage occlusion. So we do pre-procedural CT with delayed imaging, and here, push the wrong button. Here, you can see there's some proximal pectinate muscles on the ridge side, which that's kind of going to could be a little bit of an issue. You're getting 309. We do areas, so the average is 20 millimeters, and so because there's only 16 millimeters of depth, this looks like a 24 millimeter Watchman device. And so here's the TE images at 0. I'm not sure if I have to push this or not. Yes, I do. Okay. Sorry. 0, 45 roughly, and 135. And I can't put 4. Normally we do 90 degrees too. I just can't do it. But for the sake of argument, this is a stable device. There's no peri-device leak, and you'd say, well, based on all this, would you release the device? And so of course we still going to do our CT, and then on the CT you see this going on. You see that the device is constrained, and what happens distally to this device will affect the way the device behaves proximally. They're actually working on a way to make the distal end of device and the proximal end of the device more or less independent, whereby the distal end won't have influence over the proximal. But as soon as we started putting this device in, we realized that the device gets, because of it's a laser cut hypotube, and so when you compress the distal end, it'll elongate the sort of the proximal end. And if you think about the way it's built with the PET fabric on it, the fabric ends somewhere about here. So what ends up happening is if this distal end of the device, which does the job of anchoring, if it elongates, you basically are getting like a dead space out here. And that's the way I think about it. There's a dead space distally on this device. And here, there's not going to be a lot of PET fabric coverage. I'll zoom in on it for you to see. There's about 2 millimeters of coverage here. And is it going to leak? You're not 100% sure if it's going to leak or it's not going to leak, but there's not a lot of coverage. And we've seen a lot of this type of issue. And then those patients go on to have a leak. And the reason is they've got a gutter. And if this thing remodels in the wrong way and it opens up more, you're definitely going to have a leak. So we just repositioned this device a little bit deeper. It doesn't look like it's that much different, but I'll give you a sort of a zoomed in view here. And if you look at it, we just doubled the PET fabric. We did this case with 88 total cc's of contrast. That's 240 cc CTs plus 8 cc's to inject the appendage. And we do the CTs based on the pre-planning. So we already know the views. We walk in and we just execute the game plan and nothing really changes. I'm not panning around or anything. And so here it is at 1 year with 11% compression. You can see how dark it is. The Hounsfield units are going to be well below 100 here. And this is a perfect seal. Couple little things here. If you look, the Mohammed Al-Khuli paper, but there's this little bit of darkness on either side of the threaded insert or the screw, and they call that hypoattenuation thickening or HAT. And there's different grades of that, but it turns out that the fabric right here can be like lifted off. It's not really like adhered to tightly, and so you get thrombus underneath that fabric, and it basically looks like a dark thing there. And if you do a T, it's going to be fine. That's called grade 0 HAT, and it is a non-issue at all. And I'm not going to go into all of that, but that paper is really, really a great paper to kind of review all of that. And so we did this we started doing this because, so I'll tell you like a quick side story is that we started doing full cardiac cycle on our follow-ups because we would have patients and we would try to minimize radiation. So we would do like 80% of the cardiac cycle, which is diastasis. And we would do maybe a little bit of padding on that, like 75 to 85%. And we would have these cases where the appendage is perfectly sealed on that phase, but it's completely like white inside. So that means that there's contrast getting in there. And I had one and I'm like, there's no way in heck that there's gotta be a problem. So I sent the patient for a TE and there was a dynamic gap, a leak that was forming as the atrium was contracting. And so from that point, we were like, we could do this we could do this whole study for 4 millisieverts. And it gives you it's TE equivalents. I mean, you're getting full cardiac cycle, you could see everything. So we just switched to doing that. And that's what we've been doing for the last, probably year or so. And, you could see dynamic leaks, you could see the whole thing. Those are current sort of protocol. Second case here is one, and I was talking to June about this, and I'm like, hey, I ever do this to the device? And he's like, maybe looking at me like I'm kind of crazy. But remember when I was saying that the distal end of the device will affect the proximal end? Sometimes when you put it in there, it constrains it too much, and you'll have things going on in the proximal part of the appendage, and you need that device to contour to it, or sometimes just completely change its shape. That's what this is. So this is a 78-year-old male with a CHA2DS2-VASc of 6 and a Hasblat of 5 with an intracranial hemorrhage. And this is a pre-procedural sort of study. And of course, I tell you that we measure area, and of course, I didn't do it. This is not a one of our normal CTs. Sometimes I just, whatever's in there, I'll grab it. If it's good enough, I just use it. And here the T, here, if you look at the bottom left, you can see the deployment, and you can actually see what I'm sort of talking about when I say like kind of dynamic leak. You see how this thing's contracting and it's kind of moving away a little bit. And then here's the 135 view, and then there's the 0 degree view. And so, this actually looked okay. we go ahead and we do the CT. You can see the device, the 27 millimeter device, is pretty elongated. It has the same issue on the back side of the device. I mean, and there's a lot of dead space here, and it's all the way up against the wall. There's nowhere to go deeper. So we were talking to each other, Stuart and I, during this case, and we were saying, like, well, what are we going to do with this? If you go bigger, you're going to make more dead space. It's going to elongate. If you went to a 31, it's going to make it even longer. So we just decided to smash it in there and see if we could push, kind of force our will on this thing, if you will. And so Stuart was doing this, and I don't know if you've ever seen him, but he's way bigger than me, and so he, when you see this, so that's what that looks like. So you can see he's really, so this thing, which was kind of contracting and moving away from this device, he's got this device really just contouring directly in there, and he really changed the shape of it, and you could see that geometric change with this sort of head-to-head comparison here. Here's the original implant without us touching the back of the device, and then here's him muscling the device. And so this is what that looked like. We didn't do a second CT on this case. I don't think his creatinine would let us do that. But if you look at this, you'll say, okay, well, here's your pulmonary vein, left superior. Here's the ridge coming around. Now this ridge is wrapping the device, and you could see that was going to happen on the TEE. And here's the ridge again wrapping. That's not device-related thrombus. But you've got a lot more contact. The shape is completely different, and there's a lot more contact of the PET fabric with the appendage. And so here's a direct comparison of, the dead space that I say is whatever, I can't read because I'm getting old, 4.6 versus 3 millimeters. So 4.6, we changed the shape, and we doubled the fabric contact from 2.4 to 4.3. And then if you look at that at 1 year, it looks like this. It looks great. So we flare these devices all the time now. The rules of thumb are, if the appendage is really deep, you need to fill the volume up. So go to a bigger device. You can't flare something. If you've got space behind the device, it'll migrate. The device will migrate. And so as long as you're hitting against the back wall and square, you can push on the back end and get it to sort of flower out and hit the wall and change the shape. So anyway, that's a flare case. And this is an important concept to get down. This is Jackie Saul's data. She basically did 100 patients where they looked at CT versus TEE to evaluate for peri-device leaks, different breakdown of the device types. And they were close in time, 105 days versus 125. There was a 34% rate of peri-device leak found by TEE. And when you do the math on this, there's a 44% chance of, or 44% incidence of peri-device leak in those same population of patients evaluated by CT. Some of them were found to have, contrast going through the device, but there was no physical gap around it. And again, what I was telling you earlier is, if you do full cardiac cycle, some of the patients that you think are, well opposed against the wall are not well opposed against the wall through the whole cardiac cycle. So I think it's kind of important if you can do that. But yeah, this is Jackie Saul's paper. So you can add 10% to when people report their TE results, add 10. And here's our data here. We have single digit leak rate. Here's our device related thrombus rate on the first 330. And I'll tell you that the rate should be lower than that, but we made mistakes, like we undersized devices. We didn't understand the device, and a lot of things that we think we wouldn't have them today if we could do it over again, but you learn. So in summary, intraprocedural CT-guided left atrial appendage occlusion is the definitive means of validating the device prior to device release, so you can redeploy, change device, do whatever you got to do. It's efficient with taking 6 minutes. It's 3 to 5 millisieverts, minimal contrast. You can fully characterize the device LAA alignment and tissue fabric apposition. You can predict and prevent leaks and has the potential to reduce the risk of stroke. I'm going to talk a little bit about peri-device leaks and how to manage them. So we unfortunately have had to deal with this, and the way that we close them really depends on the mechanism of the leak and if we can get into the device or not. If the mechanism is multiple, like let's say you've got like a way that's getting in 2 different places, you should coil those cases for sure. So we coil them, and we use I guess I could use the brand name, but it's Trumos CX coils. And then you just pack the heck out of them. And then we use the ductal occluder if the mechanism is focal, or if you can't enter the device. So here's a case of pretty interesting case. So this is a case where the proximal pectinate muscle defeated a Watchman flex. This is very common. Proximal pectinate muscles beat Watchman devices like all the time. And even today, if I'm going to deploy a device and I get this, I'll be like, I don't know if we're going to win here or we're not going to win. And so you can see there's a gutter and it comes up and then it comes into the device. You can kind of measure this whole thing. And so the plan here was to go inside of it. I was going to coil it and then I was going to finish that with a ductal occluder device. That was the plan. The problem was I couldn't get into the device. And I could show you the dynamic CT that we see here, and you could see exactly where this thing's coming in. One thing about it is there was only one way for this to come in. So you could potentially seal this gutter itself. And Rodney Horton is the guy that kind of taught me how to do this stuff. And he's told me that he's done that before, seal these things. But you could see, if you look at this, I took an angio and you could see it kind of jetting into the appendage. What I was trying to do was show that there's this little area here. You could remember where it was like a gutter and then it was kind of spraying down into the device. Well, I mean, I was getting like, I couldn't get it to cross. And so then we deployed the device, this ADO2 device. And my TE partner, who's Ron Jacob now, he's telling me, Brian, I don't like this, And I'm like, well, I like it. I mean, you could see it's like completely sealed from an angiographic perspective. He's like, it's hanging out and it doesn't look good. And I'm like, I don't know what you're talking about. So anyway, after we debated this, we went ahead and scanned it. And what you could see here is, first of all, the appendage is definitely occluded. I mean, it's dark. You can see this device that's in here, but it does look a little wonky. Like the distal end of it is in the tract, and then the waist and the proximal end are kind of like floating out in space. And I'll show that on the full cardiac cycle, and you could really see what I'm talking about. So he was right. So basically what we did was we redeployed this. So that device looks like this: 12 millimeter discs on each side, a 6 millimeter waist, and an overall 4 millimeter of length. So we redeployed the device, and by doing so, we were able to get a much better result. A much better result. Now it works, good. So you could see that the device is here, and then that proximal disc is just filling in that little right on the outside of it. And so here's what it looks like on CT. It's just a much better result. The appendage is still dark, so we know it's doing its job. And here's the full cardiac cycle on that. So this is an example of an ADO2, which is Amplatz or ductal occluder 2 closure of a gutter leading to a peri-device leak. And this is the TEE of the better implant, the final implant. And then this is a comparison of the two TEEs where he's telling me this looks bad and he was right and this looks good. So, but it's the first one we ever did. So, you gotta learn. So, and I just did that in, I think, October, we did this case. And so here's the device, and then we released the device. So we think this is gonna be a really good outcome for this patient. Okay, now this looks a little bit like Terminator. You remember like the liquid, like the T2, where he was kind of like, could become any kind of liquid metal or whatever. This is what a coil looks like when you do a CT on the coil. So this is a Watchman device that had a peri-device leak. We went up and inside of it, coiled it, and we finished it with an ADO2. They don't normally look this good. This is the best one we have. A lot of times there's so much beam hardening artifact that you can't see like anything. But this one actually was a very good result. You could see the ADO2 finishing this thing. So that's what coiling looks like, coiling plus ADO2. I'm going to shift gears a little bit. We're going to talk about CT fluorofusion. So this system, you could co-register a CT with a live fluoro, and don't get like motion sick from this. Somebody filmed this with their iPhone. But this was us utilizing that co-registered CT to deploy. At the time, this is a PFO occluder device for this left atrial appendage. This is before Amulet was commercially available. And this is the interprocedural CT demonstrating really a perfect result. So So you can do CT fluorofusion on this system. You can then validate it with interprocedural CT. And then next year, we're going to shift to another one. So another application. So during the pandemic, we get hit with, of course, this virus and no ability to test or treat. We know that TEE is an aerosolized procedure and TEE cardioversion is the standard of care. These are all truths. So Madi and myself and Edmund Obenchima, we kind of talked together about doing something to pivot over to a CT cardioversion. So we had it under IRB approval, and we did a protocol with 16 centimeters with 40 to 80% of the cardiac cycle, and then a delayed 16 centimeter full volume scan at 80% of the cardiac cycle for the delay to look for thrombus. And then we refined this to 8 centimeter of coverage once we got good enough at it, and we had substantial savings in radiation. We did 80 cc's of iopamidol, followed by 80 cc's of contrast. And we ended up publishing this. There were 165 patients, and really it broke down into 10% thrombus, about 70% clean on the first pass, and about 20% of patients that had a filling defect in the appendage, which cleared on the delayed image. So that's sort of how it turned out. We found no death, stroke, or embolism at a mean follow-up of 175 days and no change in the GFR. And we were able to get the DLP down to, which is a measure of the amount of radiation, but down to 802, which translates into 11 millisieverts of radiation. So we found this to be a safe and feasible alternative to TE in patients before cardioversion. Now, some of the interesting things about this are, so I'll just go through it like actual case. So you want the Hounsfield units, you're looking at the body of the left atrium, you're looking at the appendage, you want it to be white, and you want the Hounsfield units to be over 100. And if you get that, then it's clear. And so here's a case where the CT shows that the body of the left atrium is 497 Hounsfield unit, it's white. Here's the appendage right here, it's 86 out here. So that's either, depending on the delay, this is either sluggish flow or it's thrombus. And in this case, it was thrombus, because on the delay, we were at 138, 162, kind of in the body and the proximal part of the appendage, and we were down in the 60s here. And you could tweak the settings, the window width and leveling to make it even pop more, but this is thrombus. And I'll show you, this case is, this is the TEE with Definity proving the thrombus and inability to penetrate into that distal appendage. So here's some of the things with doing CT cardioversion. I mean, obviously no risk to the esophagus. If thrombus is present, you never sedate the patient. You can cut anesthesia out, because we do our cardioversions with moderate sedation, but you can cut anesthesia and TEE out, and then you get your anatomy to do other things like, you could plan your appendage occlusion or do or your ablation. And then in addition, you find things like coronary disease and pulmonary embolus. And if you ask any patient if they want a garden hose put down or they want this, they pick this, overwhelmingly pick this. And the downside is there is radiation, and in stage 4 CKD, you really can't use it. So we do, 296 patients this way, and of those, there were 207 inpatients. And we cut anesthesia out, and we cut out, anesthesia and TEE. And by doing that, you could see the difference in the cost of CT versus TEE. We also were able to reduce the length of stay. And by doing those two things, we actually saved the system $1.24 million. And this, these are on that 70% of the inpatients. That's the 207 inpatients. So you think about it, when you do an inpatient procedure, you get a DRG, here's your money, spend it the way you will. So we were able to save the system money by doing this as an alternative. So we didn't really expect that, but that's definitely something that we were able to show. And then I'm going to go into this is out of my realm. These slides were compiled by Stuart Benta. I give him all the credit for this. This is his case. This 68-year-old male with an intermittent chest discomfort. It's a little atypical. He only has a risk of hypertension. There's no other, no non-smoker, no family history of coronary disease or anything like that. So a normal paradigm is, a patient gets seen, they get referred to cardiology, they get a stress test in some order, right? And then they get ultimately a catheterization off of that. And There's variable time from referral to intervention, and these time delays can increase patient anxiety and compound lost productivity on the patient side, increase encounters with the healthcare system. But what if you change the paradigm around and you said, okay, we're gonna have a patient, like a nurse triage visit. We're gonna do a CT first strategy. We're gonna do it in the hybrid lab. We're gonna get an accurate assessment of the disease of interest, and then a catheterization right there on the table if indicated. And so this is that patient. So this patient had a complex lesion in the LAD. It's tight by CT. And so he just puts the guide up and you got this tight disease. There's this is second diagonal here. That's about as much as I'm gonna do here for the coronary, And then he does a DK crush technique, IVUS guided, and gets a really nice result out of it. So if you look at it's done in this suite, but if you look at it, so patient hits the table at time 0. So angiogram 21 minutes later, the pre-IVUS, they get stented, they get the post-IVUS, and in an hour and 52 minutes, they're done with this part of it, and they're discharged in 5 hours and 39 minutes. So if you look at this normal paradigm, call it 4 weeks. We'll just say that it takes 4 weeks to get the patient initially seen, then referred, and all this. And you switch that to something that's a 24-hour, nurse visit, then they get done. So you start to say, well, wait a second, we could do that 27 times faster with this way. And we can, even if this is 72 hours to go from stress testing to Cath and intervention, if it's 3 days on average, you could do it 12 times faster this way in 5 hours. So it's, it's pretty exciting in that sort of integrated diagnostic and therapeutic arena to be able to bring them in and just take care of it all in one shot. So one of the things that I get asked a lot about, and that is, well, are you guys making money in this thing? Because, it's more expensive. And the answer is yes, we're definitely making money. It's $15 million of revenue and growing. The revenue is disproportionately from the interventional procedures. These are the CT volumes in the scanners outside of this room. And this is what it was before we started. So the dark is what the CT volumes were before, and the current CT volumes are this yellowish whatever color plus this color here. So we've I don't know, 4 or 5x the amount of CTs that we're doing. And we're bringing in really good revenue in there. And if you look at the volumes, by volume, there's a lot more CTs done than there are interventional procedures. And so this is kind of the breakdown of what we're doing in the lab: 72% CT, 28% intervention. And imagine, the CTs, you could pop them in there pretty fast. So, so a couple questions for the. Now I don't know, is this the time to do that? I'm not exactly sure, but so. Did I teach anything, and did I do a good job of teaching? I guess is the question here. Paired device leaks increase the risk of stroke. A, only if the leak is greater than 5 millimeters. B, regardless of size, leaks present at 1 year mark confer a nearly 2-fold increased risk of stroke at 5 years. Only in leaks 3 to 5 or small leaks less than 3 millimeters do not confer an increased risk of stroke. So I don't know. Do you normally do this now, or is it after, or is that how you do it? I don't know. Okay. Well. So anybody, guys, want to? B, that's it. And then device-related thrombus is more common than peri-device leaks. These are easy questions. I'm trying to make it like everybody gets 100%. So device-related thrombus is more common than peri-device leak. That is false. So peri-device leaks are in the order of like 25%, call it, and the DRT is like 3 to 4%. So in conclusion, the CT-Angio Suite is a novel integrated diagnostic and therapeutic arena. When you have conclusive diagnostic tests coupled with immediate, definitively improved therapeutic intervention, you improve quality. This patient-centered care delivery streamlines care, cutting weeks off the traditional workup, improving service and access. There's a significant cost savings to patients, insurers, and the health system. So in a value-based care model, value goes up when quality, service, and access go up and costs go down. So the CT-Angio Suite actually accomplishes all of those things. So it's a winner in both the fee-for-service world and in a value-based care world. And then I just want to give some thanks to Stuart Benton, Madi Chaudhary, Ron Jacob, and James Harvey Interestingly, every one of these is a Emory grad, every one. James was my resident. I think he was an intern and I was on Logue service. Actually, Ron isn't. He's a Cleveland Clinic guy. We got to throw him out. But I showed a bunch of people here. But James is Cleveland Clinic. Ron's Cleveland Clinic. Anyway, it's funny. It's a small world in cardiology, right? So, but anyway, with that, that completes. That's everything.
Do we have any questions from the audience at this time? Feel free to raise your hand so I can see you.
I have a question concerning CT-guided PCIs. I know you showed a case of a DK crash guided with CT, showed excellent results. My question is, if you have a very calcified lesion, how do you deal with the blooming effects of the CT?
That's a good point. Well, there's a couple thoughts about that. These current generation devices or the CT scanners, they do struggle with blooming. That's partial volume averaging. And if you get a heavily calcified vessel and you can't tell, you're probably going to have to go to do a coronary CTA. However, not so fast. And it's not in this version, but you know there are photon scanning CTs. I think when the photon scanning CTs are able to kind of get into the more mainstream, that's gonna go away because those all have a signature amount of, like you can subtract the calcium out, like literally take it out. So you could see inside of stents, and there's stuff, if you look on Twitter, there's all kinds of stuff being put out there right now about that stuff. So I would say for now, you're right. You know, obviously patient selection, you know, if you've got a 25-year diabetic, you're probably not going to want to do that strategy, right? But you know, in this patient population, they didn't have a lot of risks, and I think, but you're right. You could get tripped up with blooming, partial volume averaging. Hey, June.
So I know you do data on leaks, you know, 3 millimeters and less. So are you closing all of those small leaks? What are you guys doing?
It's interesting because what I'm doing now at this point is some of them, you know, I always try to believe that maybe they'll close on me. I've had one of them where I went back in there and waited, dragged my feet for 13 months and brought them in there and it was closed. And I was like, all right, thank goodness. So you should probably wait. If they're really small, you should probably wait, you know, and see. We are putting most of them on half dose NOAC. That's a kind of an evidence-free zone, but there's some good evidence to show half dose NOAC. You know, those patients actually do really well, like kind of in the long run. Like there's some thoughts that you should put the device in and put them on like 2.5 of Eliquis and not stop that forever and just have them on that as their sort of destination therapy. They probably do better than anything else if you kind of look at the data that I've seen on that. But we'll tend to do is we'll convince them to go back on an anticoagulant, and if they're not willing to do that, then we'll seal them. And I offer everybody to seal, but if it's really small and I think it's going to seal on its own, I kind of drag my feet.
Can I, just on that point, I just want to clarify for everyone, Brian and June, regardless of the leak, what's your practice of dual antiplatelet therapy or anticoagulation left atrial appendage occlusion device, and for how long?
Yep. So what we're doing now, we do 3 months of whatever we're doing, and then we image with CT, because I did the initial data on the first like 50 or so patients, I think 75, and we found that only 12% of them would endothelialize on a NOAC at 45 days. So when you've got contrast coming through the face of the device, you want to eliminate that as a potential way for that thing to be bright in there. So we go longer. That's number one. We go 3 months on the scans. The second thing is I think our preferred modality right now is NOAC single, like no antiplatelet, like NOAC for 3 months if they could tolerate it. If not, we do DAPT. And in patients that are really high risk, I will do half dose Eliquis monotherapy. But it's usually NOAC 3 months, and then we drop right to aspirin after a CT proves that we're in good shape. That's our sort of standard.
So what do we do, June?
Yeah, I mean, we follow kind of standard guidelines. We do, 45 days of NOAC or DOAC with aspirin and then aspirin Plavix for 6 months. So And those patients they're all getting a TE at 45 days. So anybody with a significant leak, we would potentially continue their anticoagulation and then re-image at some point. So
It's really good for the general audience that we focus on our regular practice. So on that note, a couple of questions. Number one is, what do we do for patients who you can't anticoagulate at all? That's why they're getting the device, like an intracerebral hemorrhage case or something. How do you handle the therapy there?
With that, what I always do is, it really depends. Part of it depends on how fresh the bleed is. So I get neurosurgery always involved, and I get them to say, okay, what can we do? And then they'll give us like, oh, I think you could do like half dose Eliquis for this amount of time or whatever. Like, I'll do whatever that is. And then we get them down to single antiplatelet therapy. Now, the amyloid angiopathy ones are really bad. They bleed. They don't want them really on anything. We're really hopeful that the promise of like Flex Pro, what that is going to be able to get us all the way down. And I've got like 330 patients that are in our system right now that fit that criteria. They're on nothing. They bled in their head and they're AFib with Chad's-Vasquez, 3 or more. And so I was actually thinking about doing like a study and just, randomly assigning them to, but anyway, so if you want to work on a, but I don't think I think you got to go to neurosurgery, got to get clearance, especially if it's fresh. And then you try to get them down as fast as you possibly can with, the minimum risk. If you look at it, doing platelet therapy, the risk of bleeding is the same as warfarin. I mean, it's not low, So I think the best in my mind would be if you could do maybe single antiplatelet therapy or nothing. And there is a Watchman Flex Pro study that's coming out looking at all these different regimens for device-related trauma. Because really you're talking about DRT risk, so.
just a final question, Brian. You're looking at your device-related thrombus data. So the rate of thrombus doesn't appear to be any different with the new Flex device versus the old version of the Watchman, it looks like. So what are the factors that might contribute to development of the DRT?
Things that contribute to DRT, there are some patient factors like longstanding persistent AFib is one of them. Deep deployment of the device is another factor that it definitely contributes to DRT. So there are patient factors, and then there's like, anatomical things that you do or what we do in the procedure. It is interesting because sometimes you'll see some kind of like thickening on the CT, and then we'll turn around and we'll go get a TEE to look at it. And you do see some kind of weird things like, I don't know, I describe it as like a sea anemone, like little like fibritous stuff. It's gross. Like when you see that, you're just like, oh gosh, like Anyway, there are patient factors, and then there are anatomical factors that both contribute. And actually, that, like I was telling you, that Al-Khoury paper it's beautiful. It's a quick read, and it goes through everything that you could possibly want to know about DRT in 5 minutes.
Thanks, Brian. I had a clinical question about pre-CT use in these procedures. What was your routine follow-up with imaging afterwards? And now, are you so confident with a post-procedure CT that you're not imaging at all? And what do you do down the road when somebody comes back with a TIA? Is your
that's a
go-to
good
CT?
question. Those are great questions. Before we had the CT adoption, we were doing TEEs, the standard 45 in 1 year. And then if somebody had a neurologic event, we get another CT. I think every time a person comes in with a neurologic event post device, they should be evaluated. And if you've got a good CT program, I get the CT because I'm looking for peridevice leak for DRT and the whole bit. But you got to get one of the other one because a lot of DRTs are found kind of incidentally. They're found on the 1 year. They're almost all found with the Watchman. They're almost all found when you're on single antiplatelet therapy. Even so, the Champion AF clinical trial, they did 3 months of DOAC and then waited a month and then did the imaging a month later just to see if maybe they would develop something on the single antiplatelet therapy. So if somebody has a neurologic event, they should be evaluated. And I don't care when it is. I don't care if it's 5 years later. Get it, because you'll find stuff. And it's interesting because the flow dynamics could change dramatically if you had a person that was a more paroxysmal AFib person that became like long-standing persistent. And also cardiac output going down, like if their EF goes down or their mitral valve starts getting worse and they get more mitral stenosis. Those are other factors. Like if the overall state of flow in the appendage or in the left atrium is bad, they're going to be at much higher risk for DRT.
Let's see, I'm just wondering if David Maloney, if you have any questions related to some of the work you guys are doing. But while you contemplate that, talk to us about what happens. This case you presented that Stuart Benton did, right? The Cath case. Patient comes in. What about room utilization? So how much of the time is the CT, and does that reduce the number of interventional or EP procedures you do, and how does that factor into the overall cost equation?
I think, in that case, that was one of the days where there was it wasn't, the CTs were stacked one after another. And you're exactly right. I think the ideal construct of the room, now that we've had it for some period of time, would be a situation where you have the CT scanner, there's a divided wall, and you could pick this wall up and then move it in and do what you got to do and then move it out and keep going. And some of the other vendors are actually looking at that sort of strategy. So I agree with you. Take an hour and a half out of the middle of the day and push all these patients behind and stuff. But that was a day where the lab was open and available, and we just swung them down there and did it and then executed on that. So I think it's very, you're right though.
But other than that, I mean, just give us an idea, because I see Matt's there from the lab and others. How do you decide who goes into that room? How do you stratify that? Is it all your appendage cases that go in, or I'm just trying to think aloud, if you're setting up a program, how do you justify it? What days of the week? What about the days you're not doing appendage closure? Is it just sitting around?
So it's a great space to, you will never not have something to put in the room. That's the first thing. So if you put it in there and you don't have a doc lined up to do an interventional case, you will have, the room will be utilized. It'll be utilized with CTs. It happens to be our best CT scanner for coronaries. So we do coronaries in that room on a dedicated day of the week. We do left, right heart cath, TAVR workups in that room. So we have certain days that are sort of dedicated for it. Now we are getting an outpatient scanner, and we're going to pull out some of the volume out of there. I mean, you always have to think, what's the best utilization of that space for what we're doing? And right now, because of the value added, the appendage are the cases I don't want to do them in any other environment, because it's so important to get it right, and it gives me so much good data. And we're doing 5 cases a day now in that room. So start at 7, finish at 3:30 or 4. So I think what'll end up happening is the CTs for appendage evaluation, because it's a volume scanner, it's unique in that you can do 8 centimeters of coverage, full cardiac cycle in a single beat. I think the volume scanner is even better than some of the other products, the dual source products, because they don't have the same Z-axis. So for me, what I think is going to end up with that room is it's going to be the appendage stuff, intra and post, and it's going to be certain things because we're getting a dual source scanner, we're getting a photon scanner in the outpatient arena. So
Siemens.
Siemens. So it's going to be, we're probably going to shift all the corners out that way. We're going to kind of shuffle the deck a little bit.
David, I don't know if you've got it. I thought it'd be important to just talk a little bit about some of the work that you're all doing, or any questions.
Yeah, I was just going to ask Brian, in terms of the pre-procedural imaging, do you do a 3D reconstruction of your appendage from the CT? And if you do that, do you garner any extra information besides, the other measurements like depth, area, and diameter that you're doing?
Well, there's a couple of these different packages that give you almost like a glass view where you can walk inside of it, and those ones we find pretty helpful. For example, TruePlan has one where you can kind of get inside of the appendage and see the different things that are sort of taking place. But I don't, generally speaking, grab that 3D volume and mess around with it, just because I think at this point I can put it together in my head on multiplanar. But I do a thorough evaluation on multiplanar reconstruction. But I think if there were better tools that were just readily accessible and I could kind of get inside of it and do, Stuart's always playing around with the holograms, like he wants to like look in, like, you know, but so I think it's valuable. I just think that the package that we use, which is usually the Philips and Telespace, it's not set up as well to do that.
Well, I think we need to close it. Absolutely fantastic talk. Let's give Dr. Schuler another round.